my next question is, in terms of novel therapies for CRPC, the landscape is wide open. Antibody-drug conjugates, we mentioned BiTEs earlier. What's everyone's thoughts on kind of the most promising novel mechanisms that we've either seen presented this weekend or exist across the research landscape generally?
I mean, I think you
Mike,
said some of the two big ones, right? I think the T-cell engagers, the BiTE therapies,
Yeah, I love that.
you know, xaluritamig, I think that's how you say that. I mean, that data was very impressive, right? It's like the first time we've seen substantial PSA responses with any immunotherapy in prostate cancer, aside from the small subgroup with microsatellite instability. So I would say stay tuned. There's a lot of these drugs in development, and I'm really excited to see how they sort of pan out. I think some of the ADC studies coming out are very interesting too. I think there's also a lot of interesting epigenetic drugs, which actually seem like they're gaining some traction here as well in terms of potentially being novel combinations that can work in that post-ARPI resistant population where, you know, we don't have a lot of good data to say that we have combos that work for that population.
And I want to make a comment with regard to T-cell engagers. A lot of our urology colleagues or small community practices are really stressed because right now the trials are happening with inpatient admission, 48. This is a learning curve. It is not going. We can see from the toxicity profile that at least some of them look like we're going to be able to have it on the outpatient. I mean, you know, we were struggling where we were trying to develop Ipi-Nivo, we were struggling. It was a learning curve. Before that, cisplatin even days, I've been told was, but we're going to get there. And I think there is a lot of promise, especially potentially for this highly aggressive disease. I'm not talking about your biochemical recurrence patients, but the ones who need it, I hope it's going to be a game changer.
To me, the AR degraders and PROTACs are looking very promising. Plus, they're easy to tolerate, easy to deliver, you know, oral agents. So those are definitely attractive from what I see. We reported a study of lenvatinib and pembrolizumab in neuroendocrine prostate cancer. And to your point about chemotherapy, we actually allowed up to 2 prior chemotherapy regimens. And even then we saw, again, you know, preliminary responses. The study's almost nearing completion. But we saw about 25% response rates with about 30% of the patients staying progression-free at 6 months. Short follow-up, but a really tough disease to treat again, and we're seeing some promise.
That's very impressive, actually.
Thank you.
Curious, going back to, you know, what you said about PROTACs, I'd be interested in everybody's thoughts about sort of whether we think it's going to become an approved option for patients in the absence of an AR ligand binding domain mutation. I mean, the data that was presented today showed that in the wild type groups, response rates are around 25%, which is strikingly similar to what you get with enzalutamide post abiraterone. I think it's a really effective AR signaling inhibitor, probably better than the currently approved drugs. But as far as sort of fitting it into the treatment landscape, how do you get that phase 3 trial that's positive? It's going to be challenging, I think, outside of that AR mutant population to actually show that.
No, I agree. I think that the the value is in the selected population, but also patient selection from clinical criteria is also critical because the studies are starting to be designed favoring the pre-chemotherapy population in which you're enriching for more AR-driven disease. So I think in absence of a validated biomarker and a well-designed personalized study in that way, I think rational application in the pre-chemotherapy setting is a reasonable surrogate, but we'll see how the studies are designed.
So do you anticipate it to be like a non-inferiority across all? Well, again, you can't guess.
Can't guess, but I think
I'd be doubtful they have a non-inferiority in a castration-resistant setting. I mean, there's no precedent for that. So, and to pull that off, you would need thousands of patients.
I think it's going to be stuck with mutational stuff.
I feel the strategy to market would be to do the mutation study, the resistant mutations, and then maybe they can expand into.
Now, the area I think would be interesting would be the front line, because if it really is the most potent AR inhibitor, or that class is, maybe you can move it up into an earlier strategy.
Well, I would go to high-risk localized, which still we're waiting for Proteus to report, but we're waiting and waiting. But high-risk localized, still uncharted waters.
Very good.
I think metastatic first.
One other study I'm just curious people's thoughts on was the patch trial. And are there patients now that you're going to start thinking about using estradiol patches instead of Lupron and ADT? And would you take those results and extrapolate to the metastatic setting too?
I think it's a tough sell in the metastatic setting where the majority of patients are going to receive combination therapy. So they're either going to have a potent AR antagonist or another androgen suppressing drug like abiraterone. But I think it has value for intermittent therapy potentially in the M0 population, or those select few with low volume disease that just can't tolerate ADT, and you do some sort of an intermittent therapy for them.
I have to be honest, I didn't look carefully at the adverse events. How was cardiovascular?
It was no difference.
Yeah.
No difference.
And they basically
Wow.
cut hot flashes in half.
Correct.
Yes.
And risk of sort of skeletal events was lower too with it.
And
What about anticoagulation? Did
They
have
didn't.
to put
No,
that?
They
they
didn't use
didn't
it.
see it, and they're
Wow.
arguing that because you avoid that first pass metabolism with oral drugs, that you don't have the increased thrombogenic potential.
Very interesting.
So
Yeah.
I would agree with you. I think that in general, the
I
patient you
agree.
described are the ones I'll probably look at.
Yeah.
But I'd be tempted in a guy who otherwise maybe has bone health issues or concerns,
Yes.
maybe somebody who's really struggling with hot flashes, use it for all
Switch
those
it to that.
patients because
And-
it's still going to help
and
mitigate some of
give
those
it in
side effects.
combination.
You could, because
Yeah,
I mean,
why
you're
not?
going to still mitigate the hot flashes by giving the estrogen back.
Yeah,
and I
that's
think
true.
it would help bone density too. Again, different population, so it's
Yeah.
hard, but
Yeah.
I think you're going to start hearing patients
Yeah.
asking for it because of this. So
No, I think it's a very intriguing study trading hot flashes for gynecomastia. So as we found with the EMBARK data, but
Well,
it's,
I hope that we'll
it's very
soon
good.
enough embark on this trial. I've been banging on the doors to have with a new neurokinase 3 inhibitor that is approved for women for hot flashes, and
Okay,
it really
yes.
works. I've been able to squeeze in for some of my patients, and it really works. And I think we should do a quick study to get it approved for men. And it just
I agree with you.
has some limited liver toxicity, but we monitor anyway these men like once every.
But it's
3
also
months.
attractive to use the patch for patients mCRPC, where
Yes.
you're just continuing the
Especially with
channel.
marrow
Yeah.
infiltration,
Yeah.
the
Why
idea is
not
that might
make-
work better.
Yeah, why not
I
have
think
them feel better?
the one sort of thing that is going to be an issue if we start using it though is I don't know how that's going to impact patient trial eligibility because now they're not on an
Yeah.
LHRH analog. I mean, they'll have in theory, a castrate
But
level
their testosterone
testosterone, so
will
it should be
still be
okay for
suppressed.
many
It should be
studies,
based
but
on that.
Yeah.
depends on the individual study though. It's not
Now,
say
with
mandate
the
it.
oral antagonist being present, they've kind of loosened up because now that it's been in the market for 4 years and some countries are engaging more and more,
Yeah.
they've loosened up and they're going just by the T suppression. So I think we'll be able to do
But
that.
also, we need to modify with the times too.
Correct.
You
I
know, our
agree.
clinical
Correct.
trial
Correct.
design,
Yeah.
we change the trial
Rigid.
design for the
Yeah.
patients, not the vice versa.
Correct.
Yeah, I agree.